Hello there again, I'm Tony Meekum, and we're going to start on topic 4 now, common periodontal lesions. And this is the first of our differential diagnosis topics, so here's how it's going to work. Two things every time. First, get out your study guide, because that goes through everything I talk about in these lectures. And then also reference your differential diagnosis chart. Have that in front of you, because everything we cover is going to live somewhere on that chart. And so here's the outline for today. We're going to talk a lot about periapical inflammatory lesions, periapical cysts, also things that mimic periapical inflammatory lesions from the sinus. Then we'll get into idiopathic osteosclerosis. And then starting the part 2 of the video, we're going to go into cemento-osseous dysplasia, hypercematosis, cementoblastoma, and root resorption. And so I want to show you how that works in your study guide and that differential diagnosis chart. First of all, this is your study guide along with multiple acronyms that I'm going to be using. Then we've already been through topics 1 through 3. And for this lecture, we're starting on common periodontal lesions. You'll see that this follows my videos pretty directly, and it does refer to the differential diagnosis chart right here. So let's look at that next. Okay, here's the differential diagnosis chart, and all of these boxes are split out by differential diagnoses like it sounds. When you see something that's well-defined in unilocular radiolucency, go to these charts. And these are split up by location, periapical or pericoronal. And so what we're going to talk about today, common periodontal lesions, you'll find split up over a couple of these boxes, because I'm just going to talk about the most common ones. We'll start, like I said, with periapical inflammatory lesions. We are also going to talk about cemento-osseous dysplasia, and you'll see that that's repeated again. We'll talk about some radiopaque lesions that are pretty common. And so you look down to this box for radiopaque lesions around the teeth, and we have this CHICO acronym: cementoblastoma, hypercematosis, idiopathic osteosclerosis, condensing osteitis, which is a form of an inflammatory lesion, a periapical inflammatory lesion, and then this is repeated. So some things are going to be repeated between 2 or more boxes because they may show up multiple times on differential diagnoses. And so back to our presentation here. And this is kind of the main topic for this video, periapical inflammatory lesions. The most common thing that you're going to see, and the thing that as dentists we really need to be able to diagnose. All right, I want to go through this really quick because it does pay off to know, at least at some level, the difference between acute and chronic inflammation. Acute is rapid, painful, it tends to resorb bone, so it becomes more radiolucent. Chronic is insidious, meaning it comes on slow, less intense pain, maybe intermittent, and it tends to form bone instead of resorbing bone. So that last point makes a big difference. If acute tends to resorb bone, chronic inflammation tends to lay down more bone. Inflammatory lesions can be radiolucent or radiopaque. Usually what you'll find is a mix of both radiolucent and radiopaque. Okay, and this is kind of how it works. There's a balance between osteoclasts and osteoblasts. Osteoclasts are the cells that resorb bone, so they're kind of destroying and eating bone, while osteoblasts are the cells that are laying down more bone. Now, usually this is in a balance. Even if there's no pathology, no infection, bone is constantly being replaced. It's being resorbed and being laid down. And so that bony metabolism involves a balance of activity of both of these cells. But when there's an inflammation, there's 2 different things it can do. It can stimulate the osteoclasts, which tends to resorb bones, or it can more stimulate the osteoblasts. And what you'll typically see with an inflammatory lesion is radiolucency of the apex, and if it's been there for a while, then these osteoblasts are able to lay down more bone and cause a chronic or sclerotic reaction around the outside of it. And so the appearance, it can be ill-defined or well-defined. You'll see parts of this lesion. This is your typical periapical lesion. Parts are well-defined, and then it kind of blends into the surrounding bone, which is the definition of ill-defined. Same thing here. Parts you see maybe a little bit well-defined, but it does have a little bit of a blending border. Also, what do we see around it? It's more sclerotic, meaning it's more opaque, it's more white. And so typically, as I said, you'll see both of those. When the inflammatory lesion just starts, it usually starts more as an acute thing, and the lesion is more just radiolucent. All right, and here's the chain. You have local inflammation. Usually it's caries, although it could be fracture. Anything that communicates with the pulp space then spreads bacteria into the pulp, which contains nerve, it contains vascular structures. And as the pulp starts to inflame, there's really nowhere for that inflammation to spread. And so what it does is it pinches off its own blood supply. And eventually that tooth becomes necrotic. When it's necrotic is when the infection can spread throughout the apex of the tooth. And so we have periapical inflammatory lesion. And we're not going to talk about osteomyelitis yet, but keep this in your back pocket. We're going to talk about how that could spread into osteomyelitis, or other forms of infection can spread into osteomyelitis. And if this is a severe acute inflammation, then pus forms, and we'll call that an abscess. Whereas if it's lower grade and the body forms granulation around it, a granuloma, so that's more of your chronic stage. And even furthermore, epithelial rest can be stimulated to form a cyst, and we'll show you when it starts looking like a true radicular or periapical cyst. All right, as far as inflammation in the jaws, like I said, we're going to talk about these ones a little later on, osteomyelitis and its counterparts. So for now, we're going to focus on the focal ones, periapical abscess, granuloma, cyst, and condensing osteitis. And you'll realize when you're talking to an endodontist, you got to nail down the vocabulary. Apical periodontitis is the umbrella. Under it, abscess is a reference to acute inflammatory cells, meaning there's pus in there. Granuloma is a mass of chronically inflamed tissue. And then cyst is when the epithelium is stimulated into an actual fluid-filled sac. You can pause this and test yourself if you want, but a periapical abscess coincides with what type? Chronic or acute? That one is acute. What about a granuloma? That coincides with chronic inflammation. And the periapical cyst is a sac of fluid, I didn't mention this word, but with an epithelial lining. That's the definition of a cyst. So if you get those three, you've got the terminology down. And then in terms of what you'll see in radiology reports, sometimes we refer to rarefying osteitis as just a fancy name for a radiolucent inflammatory lesion. It could be a granuloma or an abscess eating bone. Then condensing osteitis, this is a good one to know. This will come up over and over. In some books it's called sclerosing osteitis, but that's kind of the opposite of rarefying osteitis, where this refers to a radiopacity. And so this is typically when it's more low-grade inflammation, more that chronic stage, making the bone lay down more density. All right, on to some more images now. Early lesions may show almost nothing. You may have a necrotic pulp or just a very symptomatic pulp, and a lot of this is going to depend on your endodontic testing. So if the tooth tests necrotic, even if you don't see inflammatory lesion, that tooth may be necrotic and need a root canal procedure. But one of the first signs that you see is loss of lamina dura and surrounding sclerosis at the root. And then by comparison, if you look at this molar, there is a rarefying osteitis or a periapical inflammatory lesion, more the acute or radiolucent stage of a periapical inflammatory lesion. All right, same story here, but now we're seeing a little bit more of a sign where there's some widened PDL space. It's pretty subtle, but if you look close and you compare to the other PDLs, this is what an early lesion looks like. Of course, always look at the crown as well. This one has a large carious lesion extending into the pulp. And here are some various examples. There's a very sizable, pretty easily detectable radiolucency at the distal apex of this tooth, which is tooth 19. Fairly large occlusal caries, some mesial PDL space widening. Here's another lesion with mostly well-defined, although apically you could say this is more of an ill-defined lesion. So like I said, sometimes it's both, but I would describe this as more well-defined. And what I like to see is when it emerges from the PDL space like that, that's a strong sign of a periapical lesion. And then this one shows what we would define as what? What was the term for a radiopaque lesion? That's condensing osteitis. And I differentiate that from other similar lesions in that there is still a radiolucency around each of the apices. And then that's surrounded by the sclerotic bone. It has kind of a gradual transition. So this portion of it is ill-defined. And what these examples show is most of the time you're going to see a mix of radiolucent, radiopaque, especially if it's been there a while. So rarefying and sclerosing osteitis together. You can just use the umbrella term. This looks like a periapical inflammatory lesion, or PARL. Some people use that acronym for periapical radiolucency. In fact, in most cases, I don't see the term condensing osteitis unless it's very sclerotic, very radiopaque, like you see here. Here we see this opaque region. If you just look at this PDL space here, it looks normal, but what tooth is it coming from? Well, tooth 19 again. Here we have radiolucencies at both of the apices, and that's what tells me this is an inflammatory lesion and not something else that we'll talk about in a minute. And now I have a couple slides on periapical abscess versus granuloma, and you can't necessarily distinguish that radiographically. That's more of a clinical diagnosis, but abscess refers to when it's an acute inflammation, and that means there's purulence. So if you do see purulence, if you have a draining fistula that has pus coming out, then that's a strong sign that it's an acute abscess. Versus granuloma, a patient may look like this and be asymptomatic. I'm not going to be able to tell that from a radiograph, but clinically you have certain signs. If it's asymptomatic, if there's no pus, if it's been there a long time, if you have this sclerosing reactive bone, these are all signs of a granuloma. But again, that's not a radiographic diagnosis. To really diagnose this, you would have to get a biopsy and look at the cells, do the histopathic read to see what type of inflammation is in there. And the technical endodontic terms for each of these is for an acute, for an abscess, it would be acute apical periodontitis. They talk about inflammation at the periapex, so periodontitis, versus if it's chronic, then chronic apical periodontitis. So it's good to know those terms. All right, so I've talked about radicular or periapical abscess versus granuloma, And now we'll get into when it's an actual periapical cyst. Again, this isn't necessarily a radiographic diagnosis, but there's certain signs you can see. So remember, not every periapical lesion is necessarily a periapical cyst, but this only happens when certain epithelial cells, these rest cells of Malacez, are stimulated by necrotic pulp to undergo cystic degeneration. That cyst grows by osmotic pressure. But again, just like with a periapical granuloma or a periapical abscess, this arises from a non-vital tooth. So keep that theme in mind. Anything that arises from a periapical lesion, you should expect a non-vital tooth. All right, this talks about more often in the maxilla, but really it can occur on any tooth, as we've seen. So when something is a true cyst, it tends to be well-defined, corticated, round, radiolucent, and it can displace structures, less often resorb roots. Anything, if it becomes infected, can start to lose its corticated border. And here's just some examples of when I would suspect a periapical cyst. If it's this large, as maybe a rule of thumb, but it's not black and white. If it's larger than 1 centimeter, start thinking a cyst. If it has these well-defined, nice curved corticated borders, really start thinking a cyst. And the big difference here is when you do suspect a cyst, that's going to require more than just endodontic treatment or extraction of the tooth. But if it's a true cyst in there, it might continue to grow even after the tooth is extracted, and so that's going to require surgical treatment and removal. And this is an example where part of the way you can see a nice well-defined corticated border, but other parts look ill-defined, and this is where it's lost that well-defined cortex due to a secondary infection after communication with the oral cavity. Here are a couple nice clean examples. This periapical radiograph with this nice smooth, well-defined corticated border. It looks very sac-shaped. It looks like a water balloon that's just kind of adhering against the inferior border of the mandible. This is a coronal view from a CBCT, and so we're seeing this molar tooth, an expansion into the sinus, but it maintains these corticated borders around it. And these corticated borders around it tells you it looks like something coming from the bone, and specifically something coming from the apex of that tooth, which tells you this might be a periapical cyst. Remember my rule of thumb, it's greater than 1 centimeter. It has those corticated borders, so start thinking of a cyst. Another few examples. Where did this periapical cyst come from? Does it look like there's caries or something going on with this first molar? Or is it residual from this now mostly erupted deciduous tooth? So this looks like a well-defined round corticated thing, maybe starting to lose some of the corticated borders, but likely a periapical cyst from that primary tooth. Here's a top-down view or an occlusal view where you can really see the expansion of these nice, well-defined corticated borders. We use this as an example of the eggshell effect when I was talking about that, where it's able to maintain the corticated borders, tells you it's somewhat slow growing to where the periosteum can continue to lay down bone around the lesion. And this is an interesting one. There's several times I've been given an image like this and people don't know what's going on. They think it's some radiating lesion. And this sometimes happens if you had a previous periapical cyst and it was enucleated, sometimes just an inflammatory lesion, a granuloma, and then you do the root canal or sometimes extraction and it starts to heal. The healing takes place from the outside in, and that bone looks a little bit amorphous. It kind of has this radiating pattern. I call this the Eye of Sauron pattern because it looks so much to me like the Eye of Sauron. All right, so I may have certain slides where I talk about differential diagnosis. This is for when you suspect a residual cyst, what other things you should be considering. Is it just a granuloma / abscess? Might be impossible to differentiate radiographically, but when it has those nice round, well-defined corticated borders, I said before 1 centimeter, when it's beyond 1 centimeter, I start thinking about a cyst. But really when it's beyond 2 centimeters, you're really strongly thinking indication of a cyst. And we'll talk about some of these other ones a little bit. Osseous dysplasia coming up next. Because early stage osseous dysplasia, it looks identical to inflammatory lesion at the apex. So what separates them is what? Do the vitality test. And what does that tell you? Inflammatory lesion, whether it's a cyst, granuloma, abscess, or if you just want to lump those all in together as periapical inflammatory lesions, they happen on a dead tooth, the necrotic tooth. Whereas in most cases for cemento-osseous dysplasia, it's going to be a vital tooth. Now, don't take that to mean that a vital tooth always means osseous dysplasia. What vitality really tells you is it's just ruled out an inflammatory lesion coming from that tooth. That's it. Narrows down the differential. It doesn't hand you the diagnosis. It doesn't tell you 100% this is osseous dysplasia. There are a number of other things it can be that we're going to cover in this course. All right, residual cyst, I kind of mentioned in passing, but this is just a periapical cyst that remains after incomplete removal of a cyst. So a cyst that wasn't fully removed, typically it's asymptomatic. found incidentally in an edentulous area where they have a history of extraction there. If you can dig deep enough, a history of a necrotic tooth in that area. But all the other features are identical to a periapical cyst. And so remember, area of missing tooth in the mandible, it should sit above the inferior canal. These arrows show that the canal is being displaced inferiorly, which tells you odontogenic. Same round, corticated, radiolucent picture as most cysts, including your periapical cysts. And so what really clinches it for you, that'll be the history and previous radiographs, if you can compare it to previous radiographs. Management is going to be the same as a radicular cyst. Eventually, it's going to require surgery. So enucleation, that's just a term for conservative surgery for getting out a benign tumor or cyst. All right, so pulling all these together from the inflammatory group, it starts with a necrotic pulp, so confirm it with a vitality test. Then the treatment is typically root canal or extraction. If the lesion is large, so if it's larger than 2 centimeters, you're really starting to think a cyst, and that's going to require excision and biopsy. All right, now on to the sinus mimics. So when a periapical lesion sits under the maxillary sinus, it can provoke a periosteal reaction, as we see here, that thickens the mucosa. So inflammation around the tooth can announce itself up into the sinus, and you may see changes. So this shows some sclerosis, kind of like our condensing osteitis, but extending into the sinus. And this one shows the border of the lesion here. It's just kind of a small periapical lesion. But what's the arrow indicating? Well, this is just mucosal thickening. And mucosal thickening in response to any inflammation, we're going to call mucositis. We'll talk more about that on this slide. So it's localized thickening of the sinus. Usually the sinus membrane, the Schneiderian membrane, is under 1 millimeter in thickness and should be invisible on a radiograph. But edema, which is accumulation of fluid from inflammation, thickens it. So well-defined, non-corticated radiopaque band paralleling the sinus wall. This itself is inconsequential. And in fact, it doesn't always mean an inflammatory lesion. You'll see this in a lot of cases where patients are relatively healthy. And so it's worth mentioning, but typically not going to require treatment. But it could lead your eyes to a periapical inflammatory lesion if it is reactive to inflammation from a tooth, just like we saw in that previous slide. All right, retention pseudocyst, and please don't call these mucoceles. A lot of general dentists do, but that's not the correct term. We want to stay consistent with how ENTs talk about the sinuses, and to them a mucocele is something totally different, which I'll touch on when I talk about the sinuses. But a retention pseudocyst is something we'll see as dentists all the time. In this case, it looks like a little egg-shaped, dome-shaped, well-defined, non-corticated entity. This happens from blocked seromucous glands and cystic degeneration in the lining, sometimes with allergies. And why does this appear radiopaque when it's filled with fluid? Well, think of what's around it. In the sinus is air. And when I talked about context, if there's air around something, even if it's fluid, it's going to look radiopaque. Typically on the sinus floor with no effect on the sinus borders. As you can see that, no effect on surrounding structures. All right, and so how do we differentiate this from potentially an odontogenic cyst or some other form of neoplasm? Well, most of those are going to have some effect on the sinus floor. A malignancy might destroy the bone, and it won't be that nice tidy dome. The pseudocyst just sits on an intact floor, resolves on its own, they come and go. So trace the floor. An intact floor with a dome riding on the top, you're looking at the sinus, not the tooth. All right, just to give you some examples, what do you see here? Not the best sinus exposure. The hard palate line kind of overlies the sinus floor, but here we see that dome-shaped, well-defined, non-corticated entity in the sinus, and the sinus borders appear normal. This one you can see a little more clearly. Nice and egg-shaped, no effect on sinus borders. It's common for sinus borders to dip down a little bit like this, but no erosion of the borders. So this again is a pseudocyst. All these are examples of antral pseudocysts. Hopefully your eyes are starting to get drawn right to these. As I turn to them, you can look at the sinus floor. It's unaffected, no corticated border over the lesion. All of these are just pseudocysts. This one almost looks like it arises from the wall rather than the floor, but still non-corticated, dome-shaped, perfectly smooth, no effect on other structures. And so in summary, that's all our most common periapical lesions. In the next one, we'll talk more about the radiopaque lesions. And what was the big differentiator there? Whether or not the tooth is vital. A non-vital tooth points to a periapical inflammatory lesion, so whether that's a granuloma, an abscess, or a cyst, condensing osteitis, rarefying osteitis, all those imply that the tooth is non-vital. So if you have a vital tooth, you rule out those most common ones and you go to the more uncommon things. So the next video will stay the apex. We'll talk about the radiopaque things. In your differential diagnosis box, that includes the Chico and the CO5 boxes. So we'll see you on that next one. Thanks.